Hi everyone. We are now commencing our final panel discussion, and I have to say I feel completely happy that we included these many panel discussions because there's just been so much great conversation today and yesterday. So this panel discussion is called From Render to Construction Reality, and I'll just give a little introduction to our speakers. Before I should do mine. My name's Alison Hun. I'm an architect and associate director at Bates Smart in Sydney. I'm also vice chair and conference chair of the Australian Health Design Council. This session is about bridging the gap between visionary designs and the realities of construction. We're going to talk about procurement, delivery and collaboration and what it takes to make bold ideas buildable and lasting. So, who are we talking to? They need no introduction. They've all shaped hospitals, precincts and health systems we work in today. But we have Ron Billard, architect and co-founder at Billard Lease, now Ron Billard Consulting. He's been instrumental in projects like Royal Children's in Melbourne, Perth Children's, many more worth listing. Jenny Green, a registered nurse and health planner who has been involved in major redevelopments across Australia and particularly in New South Wales, formerly of Health Infrastructure New South Wales, and now Jennifer Green Consulting. Stefano Scalzo, Director of Front End Advisory, coming to us with major experience in infrastructure projects, an architect and former senior exec at VHBA, bringing experience in strategy, planning and delivery. But that's their bio, so maybe I'm just going to throw to them to talk a little bit about their journey to the stage here, across their careers. Ron?
Yeah. Good afternoon. You hear me? Good. We've set up That's on now. Now you can hear me. Yeah. Good. David Lease and I set up Billard Lease in '95. What might be interesting to people now, we think of BLP as being a health planning firm. We had no intention to do health when we set up the business case. Well, I had done some health at RMH. In fact, I did the master plan 88 and did the RMH redevelopment, 1A, 1B, the private hospital there, etc. So I was exposed to health, and I wanted to, my original passion when I graduated from Melbourne University was housing, particularly inner city urban renewal housing. So to do that, I actually went to the States and did a master's there, then worked in San Francisco, and I worked for a developer and a housing architect, so I knew a lot about it. When I came back to Australia, that market was dead because three-storey walk-ups basically killed the market. And it wasn't until 1990 it started to live up again, and then 95, we had one developer in Melbourne who was happy to do work with us, and then later we got another developer in Sydney doing that work. In our first 5 years, we'd done 5,000 apartments, which was a fair bit, and the firm grew. Our concern was, and David and I's concern was, that we were going to be exposed to one sector, which was very volatile sector. The project manager at RMH, after 2 years of not doing any work, they came to us and said, you must do the next project. It's only a $7.5 million job, you can do it. What I learnt before doing it, I got a clinical health planner to be a part of our team. Part-time, we were one of the few people to do it. Dakota Potts had Margaret Vinnie doing it as a clinical health planner, and I worked with them on the RMH stuff, so I knew the role they had, and I thought it was a very important part of providing innovation in health. And I really support the idea of what's happening now with the separate clinical health planning association. I think it's a big future. 5 years ago, David and I left the firm and passed the firm on to a collection of people, Tara and Mark, and there's about 14 owners now, and it's a more firm like a Cox or Woodsbagger or Hassels. It's got multiple owners and it's designed to keep on moving, and we've stepped out. For the first 2 years of that process, I worked part-time and now have my own firm. I've got a company. Most of my work I do now is mentoring, or not only architects, but also architects who have established practices and want to make the transition to bigger practices, and a lot of work for non-for-profit health organisations, Bendigo Community Health, and there's another one in Wodonga we're working on right now for regional mental health. That's interesting, and I'm enjoying it.
That's great. Jenny?
I'm not great at technology, so I think it's on. Is that right? Great. Good. I thought I'd talk about when I sort of got into this business, and it happened when I was working in management at Royal North Shore in nursing administration, and I had a great grounding at that hospital. Really learnt how they worked, so I understood a lot about the hospital operations, which was fantastic. But I got asked to go onto the health services planning team, and soon after we got the announcement. We couldn't believe it. Money for Royal North Shore Hospital. Northern Sydney hadn't seen money in forever, since it had been built about God knows how long ago. So that was so exciting, and I then joined the redevelopment team. And very early on in that opportunity, I got introduced to people like Sarita Chan from BVN and Laurie Neal as well, and that was a real eye-opener for me. I'd never sort of been exposed to people like that, and it was very exciting. And it was thrilling, actually. So that was my start, and I loved it, although I got burnt out and left 5 years later when we weren't getting very well. But it went on. Royal North Shore Hospital went on to be fantastic, and to this day it still is. I then went on to work for myself soon after, which was fantastic after being burnt out working for a health service for all those years. It was really great to be able to establish myself and have something to sell. I had skills that people wanted, and I was lucky to move on to jobs like Royal Hobart. I worked on the Sunshine Coast University project and others. And then soon after I got I went to, was working with Think on the Canberra Hospital at an earlier iteration. It took a while to get delivered, but you got there, which was great. But then we went to the Children's Hospital in WA, where I was really thrilled to see BLP appointed. So we worked with Mark and Ron, and I got to work very closely with Ron on that project, and we did, you might recall, research and education, which was fantastic, and he's got a great skill, like some architects, really experienced architects. They never seem to say no, but they get the right outcome, so I was always very impressed with that. So it's been a joy. Like, this work is teamwork, and that's, I think, what I love about it. And no one really wants to stand up and take ultimate credit. We're as good as everybody else is on the team, and that's what I love about it. So, yeah, that's me. So, yeah, I'm really pleased to be here, and thanks for having me.
Okay, well, that's a pretty hard act to follow. I'm Stefano Scalzo. Before I begin, I'd just like to also acknowledge the traditional owners of the lands that we're meeting on today, the Kaurna people. Recognising land was never ceded, sovereignty was never ceded, always was, always will be Aboriginal land. I practiced as an architect for 25 years, institutionalised my entire life. Prisons, hospitals, university buildings, labs. In fact, we're doing a little renovation at our place back in Victoria, and had to commission an architect to do it, because otherwise my bathroom would have a stainless steel toilet in it with a little roll. So terrible with domestic architecture. But look, and that was a fantastic experience. I was a principal at Lions for most of that time. I was the Brisbane line, which is pretty good for an old Fitzroy supporter. I got to go up and do a lot of the early work at Queensland Children's Hospital with our colleagues, Conrad Gargett. Then went back to Melbourne, did a lot of work in Canberra, Tasmania. Then was awarded a Churchill Fellowship to investigate high amenity mental health facilities over multiple levels, which then got cited in the Royal Commission of Victoria. Around that time, I joined government as the Executive General Manager of Planning and Development, so many of the projects Lisa showed earlier all came through my team, where we did all the origination and basically got the money. We watched a lot of that Scorsese film, which is Wolf of Wall Street, had to sell a pen a lot in those days, and we were incredibly successful. Having said that, though, it's fair to say the job's not done. It's not done in Victoria, it's not done in New South Wales. Yes, there's been enormous amounts of investment, but still more needs is required. I subsequently left the department, set up my own consultancy. My main client is the Victorian Aboriginal Community Controlled Health Organisation, and we've just completed a seminal study in, because of the 15 million, of course, that the state government committed, absolutely 0% went to the mob. So I recognised that was coming up and managed to use some of my annual provisions to build the evidence base to inform the business cases, which we were thankful that the state of Victoria was the first time ever in its history funded a Aboriginal community organisation to build its infrastructure. Some of the things that we'll hopefully talk about today. But that's me.
Thank you, Stefano. We're going to start today's discussion with procurement and delivery methods, partnerships or pressures. So let's start about how they're actually delivered, because the model can make or break the project. Ron, during your career, there's been a significant number of iterations of how hospitals are delivered, and I'd like you to sort of reflect on some of those models that you've been through.
Yeah, look, I could spend all day talking about this, and there's been conferences about it all too. We're thinking about, we want to talk about PPPs and the opportunities and the obligation or missed opportunities involved in that. In our time at BLP, I think we did about 5 or 6 PPPs. Only 2 out of that, and we got the 2 best ones, the Royal Children's and the Footscray. But 15 years apart, and I thought it should reflect on the differences and what changed in that 15 years. The Royal Children's, they had a very good brief, and they were very focused on the inpatient unit and a very unique inpatient unit design. They also had a good site, and all the master planners that suggested the site on Royal Park. And what they particularly wanted in the brief for the PPP was a response on the inpatient unit and response to how to use that site in a very creative way. What got built does reflect that. But there was big chunks of that building they hadn't resolved. The MCRI, 12,000 square metres, no brief before we knew 12,000 square metres. Education wasn't resolved. It was just a blank space. Even the operating theatres, we had a scheme whereby we said the journey for the parents and the child was down the outside looking into the Royal Park, and then, because the parent went with the child to the operating theatre, so that made the journey feel less scary, for want of a better word. And of course, the whole thing about the whole journey about how to come into a children's hospital is big. But big chunks of the building was not designed, not even briefed properly, but were given areas. And frankly, that was all okay. So that we designed a very complicated inpatient block and was deliberately not sitting over the car park so it could have its own structure. The rest of the building was an 8.4 metre grid. Very straightforward, standard stuff. And it inherently had a fair bit of flexibility that we could respond to those challenges. MCRI, anyone who does research labs knows that an 8.4 metre grid doesn't suit the grid of a lab space, full stop. But we had to accept it. And you can make it work, but what it means is just a little bit less efficient. Fine. When we came to the Footscray Hospital, the brief was probably way more sophisticated. And what was required was a lot more detail in the actual tender, enormous amount of detail required. And the net process of that is a lot of the risk of that job was passed on, they said, to the plenary, then to the builder, and then the last people in the line is the four consultants. And it became quite a difficult process. It's not only architects, but it's also the building services. And but the original design, the village screen and all that stuff was part of the original process and got built. What Plenary did was introduce a whole pile of innovation about the gym and the creche and where the shop was. The shop was deliberately on the edge. At Children's, the shop was in the middle, it didn't work. The shop on the edge opposite student housing, linking back into the community, was a very deliberate decision to make it work. In Children's, right next to North Melbourne, lots of quarter shops there already. You just weren't going to compete with them. So no problem about why it didn't work. What I think is happening now is they've become too complicated as processes. They're very big, and frankly, even a firm which Billard is a reasonable sized firm now, they're too big to do. And key people in the office are totally consumed, and you might lose the job, as we did on Royal Women's, as we did on Berwick, which is now Casey, and as we did on Frankston. They can become too consumed.
And in a way, you mentioned risk transfer, and I guess there's a comment there around when government says they're doing risk mitigation, the risk is going somewhere, and who that is going to. It's not disappearing.
I can talk a lot about this, but maybe we can come back later and talk about it.
Yeah, and maybe Jenny, if you want to, Ron, jump in as well. If you want to talk a little bit, I know in New South Wales, we've already touched on the changing perceptions of PVPs in New South Wales, but a lot of the projects now are being delivered within an ECI framework. Yeah.
Yes, we are terribly successful at PVPs in New South Wales, and I was going to look to Victoria. What are they doing differently? Oh, you can't hear. Yes, sorry. Yes, I was just saying. Is that right? Oh, God. Yeah. Is that right? Good. Sorry, everyone. I was just going to say we're not. Yes, sorry. We're not very successful with PPPs in New South Wales. I don't know what it is. We must be very controlling, I think. If people are following the news, Northern Beaches is just about to be handed back to the state. Now, that was a terrific process and project and very ambitious. And I was involved. I was on the assessment team, and it was great. I got 2 fully designed hospitals to evaluate, which was fantastic. But it was very ambitious, but it hasn't gone well. And when I reflect on it, I think that we really expected a lot. 2 hospitals coming together, 2 public hospitals coming together, and then being run by a third party that was a private operator. We really didn't give that project a chance, I think, in retrospect. However, we're taking it back. We've already started the process, and so that'll come back into the fold. But what we do have is a fabulous hospital. There are some issues because there's some private models in operation. There's very small pathology, outsourced imaging. Again, it'll be interesting to see what they do with that. So, and Royal North Shore, soon after that one came about, the delivery of soft FM services failed abysmally. For almost 18 months, I don't think they could get the food right. So again, as a public sector operator, we did underestimate our skill in delivery of these. We've been doing this sort of thing for over 100 years, doing large-scale food, management. The private sector couldn't do it. So it's very interesting. So, but again, that's quite a fractious relationship, and 12 more years won't go quick enough, I suspect. But we at HI, I no longer work at HI, but when I was there, we had a huge portfolio of work to deliver. So people like Martin Cook worked with industry to see how we could do it, and that's where the ECI sort of came from. And then the Beckies, a very early contractor engagement, and it's not bad. I think again, it allows us to move very quickly on our projects, and we've got HI has an excellent track record of delivery, which is fantastic. In New South Wales, it never used to be like that. So, projects took forever and they never got anywhere. So that's good. We do struggle, I think, in my experience. The contractors, are supposed to offer a lot of innovation. They're supposed to, good value for money, all of that. But the innovation, I think, comes as it's a cost saving for them often. So, and you really, on the other side, have to have the skill and the expertise to assess what they've got on offer. And I think that's often missing. So it can feel like you can get dudded, and often you don't know when you're getting dudded until you actually go to operationalise your hospital. And a great example from our program was they want to combine dental air and medical air in one system. Well, of course, that seems logical, doesn't it? Until you're at Walker Hospital and you find out you've got to get a technician up from Sydney because the medical gas now is separate, but a biomed can work on that one, but they can't work on that one. So operationally, it's very difficult and expensive and all of that. We also found through COVID that, again, another innovation, not so much innovation, what they do is game the system. So instead of meeting our air handling units is it Section J? About the Section J with your all the air handling and all that sort of stuff. I don't exactly know. But they were putting in smaller units. That means that this is during COVID. We're finding out that our 40-year-old hospital had 100% outside air capability, which saved every hospital in probably Australia. We were installing air handling units that actually didn't have that capability in a brand new hospital. Because they were gaming the system, putting in smaller ones so they didn't have to comply. So they're the sorts of traps, I think, that are out there. And when you have an agency like HI who does their best, but they're not expert in everything, and a lot of the systems that are set up to help, like a watching brief, aren't very functional, or now they've stopped or whatever. So it's very difficult. So yes, I hope that was helpful. Yeah.
Yeah, I think that there's a theme there around when change is for the better or for the budget, and I think, we talked a little bit in our pre-briefing about the role of consultants and designers in helping steward a project through design and through to delivery. Did you want to talk a little bit about it, Stefano?
Yeah, look, I'm happy to talk about that, and I'm glad you didn't ask me about PPPs because it could get back to the other founding directors of VHBA, because every time it came up at VHBA, the delivery folk would get, don't ask Steph, because he's the planning guy. But one thing I will say before I answer your question, the state can't do it alone. The state can't afford to do it alone. I had a burning question this morning about the cancer hospital. I wanted to ask them how much it cost. Now, PPP accounting standards, people would know, changed dramatically, I think, in the last 5 or so years, where the state needs to put the whole cost on their books. And so when you put the whole cost on your books, you're not just paying for... you're not paying for the building like next year, you're paying for interest on that loan for 30 years. So it costs a hell of a lot more. And yes, we can talk about how great it is from an FM till the cows come home, but you pay for it, right? And it is an expensive. On the other hand, you look at infrastructure that hasn't made the cut in this latest boom, and there are ongoing PPPs that can be augmented to add scope in other hospitals in that same network to that PPP. So they're an incredibly flexible model. It does enable the next, I think we need to be talking as a group, and I'll get to your question now. We need to be talking as a group about what the future looks like. It's great to talk about all the projects we've got in the pipe, but one of the things that is, glaringly obvious is no one's talking about the next set of projects, and that's all I did in the department was the moment they told me we've run out of money, I was out. But I think that what architects do arguably better than any and a group, there's so many architects here, I feel like I'm preaching to the converted, but Certainly in government, I was made to realise what an architect does better than anyone else, as you can consolidate into a single narrative what other people find completely disparate, right? Like there's multiple things going on, and architects are exceptionally good at being able to make them cohesive. They can find patterns where no one can. And I think that we need that way of thinking to think through the wicked problem that we've got before us at the minute. And that is a combination of a lack of money, a risk appetite that's ever looking to diminish the risk amongst government. And there are, changes in AI, all the things that we've already spoken about. But I think it does require the practitioners in the room just to go away and do a bit of thinking about what the future of the type looks like. Because whenever an architect is dealt, a wicked problem, they generally can go back to first principles and think through the problem and come up with a new bricks and mortar solution. And for me, definitely, and Ron and I share a board role at Bendigo Community Health. I mean, in Victoria, at this conference, it's been interesting, and unfortunately I've only been able to attend one day, but we've only spoken about acute health, and mainstream health. I mean, it's great to see the Canberra project, but we haven't seen one ACO piece of infrastructure. We haven't seen one piece of community health infrastructure. And in Victoria, many people would know CoHealth, one of the major not-for-profits, is closing its buildings, it's closing its services because it can't operate out of what are condemned buildings. Now, if we thought differently about how we could design these facilities, how they could be procured, how they could be funded, then I think we as a group can actually imagine the next 20 or 30 years worth of projects. But until we've done that, I think it's not looking, from my point of view, it's not looking particularly sustainable unless you live in WA at the minute.
I'm going to put a pin in that for a minute, and we'll circle back to the next. We'll close on this as well. I think we'll come back to this. Before we kind of forecast in the future, just to talk about right now at this precipice, we've talked a lot about new models, and we know that states and territories are looking at delivery and looking at new ways of getting all these buildings built, whether they're big or small. What is the things that we need to not lose sight of, whether it's ensuring good design through a procurement method, or if it's just about understanding the basics? Jenny, I know you have a lot to say about good design basics.
Oh, yes. Well, we were talking in our previous session about whether you standardise, and there seems to be a really big trend, particularly in Europe and the UK. We talk about it at HI, or we did when I was at HI, and New Zealand seems to be going down a path as well, which is interesting. Look, I think things like standardisation have stood us in good stead. And I think it's something we should focus on, particularly for repeatable, units like wards. When I started nursing, people used to come in 7 days before theatre. They used to sit around on their beds. It was a very different time. And I think that hospitals are now used predominantly for the elderly. They're old, they're frail. They've got comorbidities, disability. So those environments, whatever we do, have to suit the aged and disabled, and they have to suit the workers, the nurses and allied health and whoever that care for those people. So that has to be our priority in the design. And so I think that those principles are really utmost in my mind whenever I'm doing a hospital, that the spaces have to be usable. Standardisation in wards, for example, has worked very well for us, and over time. I spend a lot of time at Westmead Hospital and in the old building. Now, that old building is now 47 years old. The wards there, the original ones, aren't too bad. Like, they look dated, decor-wise, but I tell you what, they trick up when they're renovated. So that footprint of those inpatient wards, you wouldn't believe what what we can do to them. So I think that those sorts of approaches, as healthcare changes, and a lot of us here who have worked in healthcare have seen HIV was an inpatient ward and went away. And diabetes has gone away. It's there, but it's ambulatory. Day of surgery models and day surgery models have got a lot of those patients out of traditional inpatient wards. So that's great. I think where we go wrong with sort of our design sometimes is we do try and think everything's the same and standardise too much, and that's when skill and understanding how people work comes in. So outpatient departments are a fantastic example of that, whereas everyone says, oh, we just need 50 consult rooms. Well, actually, you probably don't. You probably need, a interview rooms. You might need a room that works for early childhood nurses. So it's not one size fits all. Most of it probably can be, but we really do have to understand the unique requirements of individuals. And a gym for an adult isn't suitable as a gym for a paediatric presentation. So there's all of those things to think about. But really, I do think that we do. I'll speak to my experience at HI. A lot of the time we do see change as innovation or just an idea as innovation. That's not innovation. That's a bit irresponsible, actually. Ideas of innovation do really need to be tested, whether that's through an evidence base or through prototyping and testing. And as someone said before, what problem are we trying to solve? So a lot of what we're doing isn't broken. There's a lot of basics in the work that we do that won't change. Yes, we do improve the environments. They're lovely. Like, you go into our new hospitals, they're just delightful. And Campbelltown, the shared spaces there, that's just one that springs to mind. So they're very, very good. So I think with innovation, I'm all for it. But I do think that we do need spaces that work for our patients and the staff that care for them. And those patients, really, the focus needs to be on maintaining their health. We cannot afford for these people in hospital to be stuck. They can't actually be as independent as they might because they deteriorate, and some of them never get back. They never get back their function, and they'll go to aged care, that sort of thing. So these maintenance, these spaces that really enable patients to be independent is really important. So I hope that was all right.
That was great. I think a little bit of what you're saying in terms of standardisation is around, especially Westmead, is around that idea of long life, loose fit. And I think, Ron, you touched on a little bit about that. And what else do you think, Ron, would be innovations that have that real staying power that you've seen, last?
Victoria has community health services which are independent from the network and independent from the state. But they have power to borrow money, they've got their own boards. And I think more of deferring, rather than 50 consultant suites, put 10 in each of community health services around the place, close to where the people are. And inherently they should have flexibility. Inherently they're going to be cheaper to run, cheaper to staff. They'll be able to pick up Medicare financial support from the federal government rather than just being all state. And they're also very flexible to respond to unique programs, particularly in country towns where there's Aboriginal support like the one in Bendigo or whatever the unique parts of Maryborough and those unique issues. And they can respond quickly to it rather than being caught up in a big network. Coming back onto the delivery, I think what we should do is, I think the very big Footscray type projects, I don't think there'll be many more of them for a little while because they're just too big. But the idea of the advantages of them is you can get innovation. You can get innovation in design, which I think the two I've talked about shows quite clearly. But you could get that innovation by running design competitions with the key element, like in children's or the inpatient unit and use of the part. And do a little bit like in Europe, they do run design competitions for hospitals. And you get the first bit to sort out the best architectural thing. Then you should run a design competition for the services. And I think services, we need a lot more innovation. But what's happening in services, when you wrap it up in a PPP, they actually drop the innovation because the builder takes over and goes to his subby and gets a cheaper job than the innovation provided by the service engineers. But I think innovation we talked yesterday about electric buildings. Well, I think the big innovation is how to use the cheap free power in the middle of the day to store it store it in the hospital like a big battery. It's not a battery. Royal Children's had a chilled water tank in the basement. Actually, it got deleted before the building got built because the state government said, "Oh, we've got a really good contract with the supplier, and we don't even pay night rates." Well, now it's not night rates; it's how to use the power in the middle of the day when you've got excess. Think through all the innovations you can do, and get the right team to bid for it. And the same could happen with finance. I think what's happening now in finance is the super funds are financing it. Well, get that packaged up and sort through it because the government needs it. The same can happen with respect to other co-located services.
In a way, you're talking a little bit about incentivising industry to provide good design rather than maybe, meet a very long list of requirements, I guess.
Yeah, package it in a way where you can see what's good and what's not. That's where I'm doing it. Because when it's wrapped up in a great big bundle, one team out of 3 wins. And often, not all of them are the best bits of everything.
Yeah.
Be it maintenance, whatever.
So I think everything here is a little bit about scale as well in terms of over-packaging. And I mean, the fact that we're talking about projects being too big to deliver is all in that. So I think it's been great to see projects of all scales in this conference. I'll end with, I guess, another look forward. So, Stefano, this is your chance to tell us about what opportunities you see in community-based Aboriginal-led health models.
Oh, well, look, I think what's interesting in Victoria, we just had 2 independent Infrastructure Victoria reports on the state of infrastructure, health infrastructure, neither of which dealt with mainstream or acute care, which has been really refreshing. So they've, this is the independent to government body basically writing the first ever report on ACO infrastructure, which we co-authored at Bacho with them. And it spoke to the need to address the fact that most of the existing estate is culturally unsafe. It's just hand-me-down, mainstream cop shops, schools, where all sorts of colonial racism has happened, none of which has been addressed in the community, none of which, and quite frankly, the state's not obliged in the Health Act to do anything about it, right? Because as Ron said, these are independent groups, and the state is not obliged. So you do need that groundswell of treaty. You need that you need a much more mature conversation about these sort of things. And we were successful in getting government to invest in ACO infrastructure, and we're doing more. But I think the future does, and the second report is on mainstream community health infrastructure, which just came out about a month and a half or so ago, asking to collect the data on the state of the actual portfolio. Like, no one knows how bad community health infrastructure actually is in the state of Victoria. I mean, but you've got groups needing to close because of the state of that infrastructure. So unless, and for those of you who have dealt with government and business cases, unless you have the evidence base, you've got buckleys of getting any money. So Infrastructure Victoria has basically said you need to build the evidence base. So I think what the future does look like in terms of there is a real recognition, certainly in the conversation that is being led by Infrastructure Victoria, about the need to invest in the primary end of the spectrum. I think there's an enormous backlog of investment, but they're not going to be doing that all themselves. They're going to be looking at partnering models, small-scale PPPs, simplified partnerships, working with the consortia at the moment. They're looking at market-led proposals a lot more. I think I've bowled up at least 2 in the last year or so. And what's interesting, going back to Ron's point, is community health are there to be able to, defray demand from the acute sector. But there's no point in putting it 10 kilometres down the road. It's almost like, and this comes back to the architects in the room will understand the urban precinct concept, co-locate them, God forbid. You might even co-locate a community health facility with an acute centre. You might even co-locate an ACO with a mainstream hospital. And we've just about to crack the code on that in Victoria with the first ever Aboriginal community controlled organisation co-locating on a campus of Monash Health. So I think, they're the kind of typological differences that architects are very good at thinking through, mashing things up, seeing where it goes, detecting the new patterns, and often thinking about them at an urban scale, and then bringing those silo types together in a precinct, which can be enabled by different funding mechanisms. A lot of those super funds also happen to support most of the clinical staff that is actually in those hospitals. So, it's not hard to build an argument for those super funds to fund its members' outcomes.
Yeah, and that community health would be important in other ways to do things. They've got lease space, which needs some massive upgrade. Is that worth coming in? No. Use that one. They've got lease space, which is probably about 80 years old, and it doesn't comply. It is really bad. And we've been talking to them about, why don't you lease some space from somewhere else, or why don't you meet up with one of the community house organisations, housing providers, and you just want the ground floor, and put them upstairs, and you go in this together. And you do a... A bit like this development, absolutely. And we've got to think differently. Now, the thing about community health, they've got the agility to do that because they've got an independent board. You try and do that with... And Steph talked about how he tried to do that in the community hospital space. It was too difficult in the state government to break it up that way. But I think there's some opportunity to be quite innovative in those solutions.
Jenny, if you want to add something from the health planner's perspective in terms of outside the hospital, health outside the hospital.
Well, I've been working on lots of exciting projects, but I think we can learn a huge amount from the outside. And some really good examples are aged care. And I think somebody mentioned today in Victoria, I think it was the head of something or other, said that they do a lot of residential aged care. We do that as well in New South Wales. So we do want to learn from the best. Traditionally, we ran those services like they were a mini hospital, and which is horrible. Horrible. So we did a lot of work in that space, and that's really looking at what best in the industry was doing. So that was really important. And now we've got the design guidelines. The way that aged care worked for a long time. They used to have guidelines. They took them away. And so it made it very difficult. So I think that there's a lot to learn there. We've got, in the community, we're doing a great, HI, and I'm actually on the project still, is what was called PCLI, Pathways to Community Living. And to me, Stefan, you said a lot, we're doing a lot about acute hospitals today. The most exciting project at HI, I thought, was Pathways to Community Living. So what we were looking at is based on a lot of great stuff that was happening in Victoria and particularly South Australia, was long-term institutionalised people who we realise after 20 years probably shouldn't have been there. Shocking. And so now what we're doing is trying to give these people their lives back. And that's through community housing, supported community housing and different levels. A lot of the NDIS will step in through group homes, but that's really exciting work and really partnering with architectural teams, for example, but also our experts in the ministry who are incredibly invested in changing these people's lives. And it's going to be hard work, and places like our big capital cities now, to even get a block of land is incredibly difficult and expensive. So it's increasingly difficult to get these projects to stand up, but it's really important. We have also learning a lot from industry about different things. So a great project that, again, we can learn from industry was we were doing a massive ambulance project and with what was called a make-ready model. So it was from the UK. The ambulance couldn't put it together, so I had to work with them to get it. But what we did one day was visited the bus depot at Leichhardt and see how they manage their vehicles. The buses there, it was one of the best couple of hours I've ever spent in my career, because how nimble they were, the systems they had, really systematised processes, and ultimately for ambulances, getting paramedics back on the road and with patients, and not, at the end of every shift they had to wash their vehicle. And oftentimes that was done at overtime rates because they'd had their 12-hour shift and then they had to stay and wash their stupid car. It's just crazy. This is the sort of thing that we just can't afford to be doing silly things like that. So I think we're also in health, people would be aware, we've got a lot of people with behavioural disturbance now, and again we can learn from the best out there, and whether that's hospitals who specialise in that, but those sorts of environments, we're experiencing that in our EDs, in also, it's not the ward that looks after those patients, they're everywhere, so we really do need to learn, and that's where we have partnered with university partners, people like Peter Fleming, isn't it? From the fellow from Wollongong University, and to that start us on that journey. But there's Richard, that's right. Sorry, Richard's here. Yeah. Oh yeah, Peter. Sorry, Peter. That's right. I used to work with Peter at HR. Good. Sorry, it's been a long day. So there's so much to learn, and I think in health we've got to get away from we know it all. And we've got to look at different. I'm all for it, because I think we can't keep going on with hospitals. Like, everyone's building all these beds. There's no one to look after anyone, and I think we really do have to get back to keeping people well, and having a broader idea of health.
Thank you. That was amazing. Final words, last words. You're all incredible mentors to industry. What would you like to see the industry and the next generation look at in the next couple of years?
What would I really want? One of the things I do is give a couple of lectures at RMIT every year, and it's interesting because this question gets asked. There are a whole lot of young practitioners, and I think don't lose sight of the fact that your practice career can actually take the stint of being on the client side, to be in government, to go upstream, get your hands on the handles, commission the research, write that brief that you wish you could be doing. I think that we and I know there are more than architects here today, and I keep on going back to architects, but I think we as a profession probably need to support people to go and do their tour of duty, right? I felt that's exactly how I felt when I was I did 2 tours and then dropped out. But I feel like we need some of that experience from the delivery of these projects to go upstream into how do you get them funded? How do you talk to Treasury to talk to them about the efficiencies, talk about good design and all those sort of things. And the more we get practitioners to do that, I think the better off we'll be.
I think it's really good to support younger people coming into health in our industry because we need them. Health, there's going to be a long lot of business, and I think a lot of people that I see out there aren't very well supported. They're thrown into situations, and that many of us who've spent a long time doing this, it's not easy. you have to be very resilient to deal with a lot of the people that we deal with, and you know, day after day, month after month. So those people do need to be supported. So it's in all our interests, and it's actually it's a really enjoyable part of my job. And I think we've got to get back to projects being fun. Like, working on a project should be fun. It shouldn't be awful and we dread it. And so we've got to, you know, make those, you know, really expect every participant to, you know, respect everybody, what everybody brings to the table, and have a bit of fun. Yeah, that's what I'd love. Yeah, and it can be done.
You know, I've had great fun in my career. I think the thing about architects is we're divergent. We think creatively, and as Steph talked before about how we're good at that, and I think we need to keep on doing that. And we need to also do it in different ways, like Steph was saying, work for the government, work for the builder. There's nothing wrong with that. And work for consultants and project managers. But think about the core idea why you're doing it, and make sure that you haven't lost that, because I've seen design managers which were good architects come across on the builder side and become really nasty design managers who are just dotting I's and crossing T's. And that's not the answer.
We're about to close, so is there any burning questions that anyone would like to ask the think tank?
Chat over drinks.
Chat over drinks. Oh, okay. Okay, the chat over drinks. Okay, so if you just indulge me for a couple of minutes while I close the session. This conference was called Design for a Changing World. It was inspired by the pace of transformation we are all experiencing, and from shifting landscapes in infrastructure to the changing needs of communities and the environment around us. It's a reminder that good design isn't static. It evolves with its context, and it helps people adapt, connect and thrive. I think it's safe to say we've covered that topic in many forms in the last 2 days, and I'm really thankful for everyone who's participated. So on behalf of the Australian Health Design Council, I would like to thank everyone who's made this possible, our speakers and partners, our volunteers and our committee who have contributed their time and effort to making this event a success. Just as a reminder, as a non-profit independent organisation, we are powered by the passion and support of our members. Everything we do, from research to advocacy, is made possible by the collective commitment to better health design. So please join us for drinks and nibbles downstairs, have a chat, and safe travels home. Thank you so much.